If you have ever followed the rise of artificial intelligence in medicine, you have probably noticed that many clinicians and healthcare professionals remain cautious, if not outright skeptical. Despite all the excitement and promise, there is a persistent sense of doubt. So, what is fueling this skepticism? What is at the root of the trust gap in clinical artificial intelligence? Let's start with the initial excitement. Too often, new artificial intelligence tools are introduced with great enthusiasm. Clinicians are hopeful and eager to try these technologies, expecting them to improve their practice. However, when these tools are actually put to use in real-world clinical settings, they frequently fall short of expectations. This repeated cycle of hope, followed by disappointment, has led many to become wary of the next so-called breakthrough. Before we go deeper into the reasons for skepticism, it is vital to clarify something that I always mention in my presentations. There is a big difference between general-purpose chatbots and task-specific artificial intelligence tools. Chatbots are designed to return a response that is statistically consistent with what an expert might say in a given scenario. However, they do not possess true understanding and are not suitable for situations where clinical decisions are high stakes and require precision and accuracy. Task-specific machine learning algorithms, on the other hand, have been built on decades of development in the field of machine learning. These specialized tools are trained on vast collections of expert annotated patient data, usually numbering in the thousands or even millions. They can be systematically validated to ensure their reliability and effectiveness in real-world clinical applications. It is important to recognize that the field of machine learning has been evolving for decades, well before the recent surge in popular chatbot technologies. Its history dates back to the mid-20th century. However, despite the significant progress, the limitations of this technology mirror our own shortcomings, rather than being flaws inherent to the algorithms. One of the major sources of skepticism is the persistent real-world performance gap. Artificial intelligence models often show impressive accuracy during development, but their performance can drop significantly when they're deployed in real clinical environments. This disconnect between what developers claim and what clinicians experience is at the heart of the trust problem. A key reason for these performance gaps is something called overfitting. Overfitting happens when models memorize the specifics of their training data instead of learning the true underlying patterns related to medical pathology. Sometimes they pick up institution-specific artifacts, details from a particular scanner, or spurious correlations that do not generalize to new patients or different hospitals. This is not just an issue of validation at the end of training. It is a problem with the training process itself. To make sure artificial intelligence models are truly reliable, we must assess the health of the training process itself, not just look at the final accuracy numbers. One effective way to detect unhealthy training dynamics is to examine how the accuracy values change throughout the training process. By looking at the shapes and relative positions of the training and validation accuracy curves across the span of training, we can determine whether the training was healthy and whether the final reported accuracy is trustworthy or simply a result of memorization. It is vital not to blindly trust high accuracy values. Always look for the proof that the training process was healthy in every report or publication you read. High final accuracy numbers can be achieved through unhealthy training, which makes the tool unreliable when applied to real-world patients. Some may claim that documenting model performance on an external dataset is enough, and that they do not need to show you proof of healthy training. However, developers should not even bother testing on external datasets unless they have first demonstrated healthy training dynamics. While some drop in accuracy between internal and external testing is normal and even expected, it must be a small drop. If a model claims 99% accuracy on internal data, but only 78% on external data, that is a red flag for overfitting. That's too big a drop. Always demand proof of healthy training. And remember that many so-called external datasets are not truly independent. Just because data was collected in a sister hospital across town does not make it genuinely external. The field of quality assessment for artificial intelligence is evolving. Our frameworks must adapt to keep up with new challenges. Integrating training dynamics into these frameworks is key, so we can ensure that models are not only high-performing, but also reliable and trustworthy in the clinical world. When you review studies, only assess those that report both training and validation accuracy curves showing convergence without divergence. If a report does not show this, it should not even be considered. Final accuracy values are only meaningful when accompanied by evidence of healthy, convergent training and validation curves. Look for stable validation performance across the training process, rather than erratic or fluctuating behavior. Consistent and smooth validation accuracy curves indicate healthy training and greater reliability. In contrast, unstable curves may signal deeper problems with the model or the data. Beware of models that have simply memorized the data instead of learning meaningful patterns. Memorization often leads to poor generalization and unreliable performance on new cases. Always confirm convergence behavior in training and validation curves, which suggests the model is actually learning useful clinical patterns. If you want to learn more about how to rigorously assess machine learning classification models, I invite you to check out my 2 books. These resources provide clinicians, researchers, and healthcare administrators with the tools and frameworks needed to evaluate machine learning systems before clinical implementation. The goal is to give you the confidence to make informed decisions and avoid common pitfalls. Another key message is the importance of interdisciplinary collaboration. Effective artificial intelligence tools require deep and ongoing cooperation between developers and medical professionals. Clinicians provide vital domain knowledge that guides data splitting and feature selection, preventing models from becoming useless in practice due to overlooked data issues. Without this collaboration, artificial intelligence systems can easily miss crucial clinical nuances and fail to deliver reliable results. Educational institutions have a vital role to play. They must empower medical professionals to actively participate in artificial intelligence development. By incorporating artificial intelligence, literacy, and hands-on experience into medical education, institutions can ensure that future clinicians are prepared to lead, collaborate, and make informed decisions about the use of artificial intelligence in healthcare. It is essential for both future and current medical professionals to understand the basics of artificial intelligence development and training. They need to learn how to spot red flags in machine learning models, such as overfitting, bias, or lack of generalizability. Gaining these skills will empower them to collaborate effectively with developers during the design phase, ensuring that artificial intelligence tools are safe, reliable, and clinically meaningful. Medical professionals should be active participants in the artificial intelligence development process to ensure that tools truly meet real-world clinical needs. This includes paying close attention to how data is split, which features are used, and how validation is performed. By intervening early and advocating for rigorous testing and validation before deployment, they can help guarantee the safety and effectiveness of artificial intelligence solutions in healthcare. I am Dr. Milan Toma, an associate professor in the College of Osteopathic Medicine at the New York Institute of Technology. My journey has been shaped by the brilliance of our medical students combined with my own computational expertise. Together, we have published nearly 40 peer-reviewed studies on artificial intelligence in medicine in just the past few years. These studies laid the groundwork for my books, and I am profoundly grateful to everyone who contributed. Thank you for listening.